Error. Electricity in line. Override accepted. Infusion initiated.
Welcome to the INS Infusion Room, the official podcast of the Infusion Nurses Society. In this podcast, we explore all things infusion therapy through a real-life conversation, covering the latest trends, new research, evolving standards, and key industry insights. Whether you're an experienced infusion nurse or new to the field, we aim to keep you informed and empowered with the knowledge to stay at the forefront of the profession. My name's Derek, and I'm your host. Let's dive in. Hello and welcome to another episode of the INS Infusion Room. Today we have Dr. Van Doren back in the house for our second part of our special three-part series of IV iron infusions. And I want to make mention that today's episode is sponsored and brought to you by Pharmacosmos Therapeutics. Welcome, Dr. Van Doren. Thanks for joining us again for another episode. So just to kind of recap, we're taking us back from the previous episode. We're now going to move into hypersensitivity reactions and what's CARPA and how does that directly relate with IV iron?
Yeah. So this is such a hot topic. I get so many questions about this. People email me all the time about hypersensitivity reactions. So definitely a great topic to cover.
You know, and honestly, whenever we had the webinar, this was a huge hot topic. People were just really mind blown from some of the information that was presented in that webinar. And taking it back to that, this all stemmed from that webinar happening back in February, where Dr. Van Doren came on and talked all about IV iron. It was well attended and lots of questions that came from that we really wanted to address in this three-part series. For our listeners who maybe they don't understand exactly what CARPA is. What does CARPA stand for?
It stands for complement-related pseudo-allergy, meaning it looks like it's an allergic reaction. It looks like it could potentially be an anaphylactic reaction, but it's not. And I think first I'll back up and just talk a little bit about the physiology of what's
That'd be great.
involved in allergic reactions so that some people can recognize the difference between the two. So we all have these white blood cells in our body called mast cells. And those cells are the cells that mediate allergic reactions. We have to have an exposure to an allergen, and then it's upon the second exposure or third or re-exposure that we run the risk of having an anaphylactic reaction. So what does that look like? It basically looks like CARPA, which I'll get into. So you can have pruritus, maybe a little bit of shortness of breath, some flushing, but with anaphylaxis, you will absolutely have hypotension, so decreasing the blood pressure, and tachycardia. And you might even have, or the patient might even have some neurologic deficits or sequelae of that. And so that is what an anaphylactic reaction looks like. It's an emergency. It usually happens very quickly and needs to be treated promptly.
Very promptly.
CARPA. What did you say?
Very promptly.
Very promptly. So on the other, and it can be quite scary. It's an emergency. That's the point. And so sometimes people, they don't have time to wait. Is this going to be anaphylaxis? What is it? I just know it's some kind of hypersensitivity reaction and I'm uncomfortable with it, right? So CARPA kind of looks like anaphylaxis, but without the hypotension and without the tachycardia and no neurologic sequelae. So it is not an anaphylactic reaction. But why does it happen? So it's not specific to intravenous iron. CARPA can be seen in, it's basically a form of a hypersensitivity reaction. It can be seen with any kind of intravenous medication. We see it with chemotherapies, we see it with biologics. And specifically for intravenous iron, remember in the previous episode, I was talking about the sugar molecule and how tightly it's bound to the iron, right? So what happens is whenever some of that free iron gets released into the blood or disassociates with that sugar molecule, our body reacts to it. And it activates a part of our innate immune system, which is called complement. And thus, that's complement associated or complement associated related pseudo-allergy.
Yeah. It's a lot to, that's a mouthful there. CARPA.
Related pseudo-allergy. So I think that the main points to remember about CARPA is that it will resolve on its own. And there is no hypotension. There is no tachycardia or extreme tachycardia with that. And so what happens is if people pull Benadryl off the shelves to treat CARPA, when a patient is administered intravenous Benadryl, it can actually drop their blood pressure. So then it can start to look like it's anaphylaxis, right? And then if you give someone epinephrine, they become tachycardic. And so it
Yeah.
can look like anaphylaxis. But usually the recommendation is to stop the iron infusion, just watch them. They will recover within the first couple of minutes, and it can be very uncomfortable for patients. So the infusion should definitely be stopped.
So just to kind of recap, hypotensive, tachycardia, and what about tightening of the throat or shortness of breath? That would
Oh,
be
yes.
yes.
That too.
So if you don't have those three, then we could slow it down and assume that it's CARPA,
Yeah,
not the allergic or anaphylactic reaction.
exactly. Yes.
Great. That's good information. And I love the way that you explain that. You really break down and make things so much easier to understand. So thank you for that.
Well, clearly it's tough because it's a tongue twister, even just saying carb.
It really is. So is it appropriate for a clinician to document a CARPA as an allergy in the chart?
It's really important to document the reaction. And the reason is because, again, if it's documented as an allergy, it may not be a true allergy. And when a patient experiences CARPA, they can actually be re-exposed to that same iron infusion again, and they may have no reaction the
Hmm.
second time. But once it's listed as an allergy in the chart, then usually the patient's not re-exposed to that. So then that's an intravenous iron that's kind of off the table forever and ever.
Yeah. No, that's a very good point. Especially whenever we're looking at AI and technologies and charts to really
Mhm.
help the clinicians at the bedside identify these things. That is
Mhm.
something to consider as we further incorporate technologies and telling the technologies what to monitor for. So that's a really wonderful point.
And I think it's also important to have really good documentation of the type of reaction, the
Hmm.
symptoms that actually occurred during that reaction. And one of the other reasons is because a lot of the data that's pulled out of charts for manuscripts or publication is usually going to be data. It's either allergy or no allergy, or anaphylaxis versus no anaphylaxis. So when we just pull those out of the charts and we publish something, then the rate of anaphylaxis may even look higher for intravenous iron, when in reality, we only see it in about 0.1%. That's the rate of
Okay.
anaphylaxis for intravenous iron.
Wow.
Yeah.
Wow. And that's a very small number. And I would have thought that was much higher based upon how diligently we are looking and assessing for this. And just misidentifying these two can really make a huge difference in the success rate of giving these patients what they truly need, right? So, if we were to pre treat a patient for a hypersensitivity reaction, are there specific medications that you recommend?
Yes. So I will say regarding pretreatment, the only data that exists for pretreatment is a publication many years ago, maybe 2017, from Michael Auerbach, and showing that providing intravenous or methylprednisolone prior to intravenous iron infusion prevented next day arthralgias and myalgias, because some
Nice.
patients can experience that. However, if a patient has had a previous infusion reaction or they have multiple allergies where the clinician is concerned about the potential for any kind of reaction, it would be perfectly fine and appropriate to treat with a steroid and Pepsid potentially, not pre-treat with Benadryl, because remember that can decrease the blood pressure.
Yes.
There's just no evidence for it, but there's no evidence to not do it either.
Okay. And you said Pepsid. How does Pepsid work in preventing this type of reaction?
So Pepsid stabilizes those mast cells, which are also implicated in CARPA. And so you don't get that granule release. And so that's how Pepcid works.
Wonderful. So let's talk a little bit about post-infusion monitoring.
Mm-hmm.
I know that there's some differences between facilities and what that policy states for post-infusion monitoring. Can we talk through the differences and kind of what to expect for maybe a clinician who's following a policy that does not need to do a post-infusion monitoring versus a facility or organization that does have a policy that supports this monitoring? Why is there such variance?
Well, I think it's a matter of whatever the level of comfort is of the providers and the nurses caring for the patients receiving intravenous iron at that specific institution. I've been at institutions where there's no monitoring. Patient finishes their intravenous iron, they get up, they walk out, and we give them a very explicit return precautions. And then I've been at institutions where they monitor the patients for 30 minutes afterwards. And it's just a matter of what the policies are at that institution. So, and the level of comfort, I suppose.
So for the patient that tolerated the iron infusion, but they maybe have developed hand or feet swelling 30 minutes after, how would you treat that case?
I have seen that. I have seen that with one specific intravenous iron formulation when given at high doses with Venifer. And I believe the reason that these reactions occur is because Venifer was not meant to be given at such a high dose, because it's the iron formulation where the glucose, the sugar molecule, is not tightly bound to the iron. So at higher doses, we can see pretty severe reactions. And in fact, all the intravenous iron formulations, out of all of them, there's only one that can be given or has an FDA approved label to be given as a total dose infusion. You probably know that's ferric maltose. But the swelling will go down over time. So there really is nothing to do with the hand or the feet swelling. If you give Lasix, it probably won't help. It will usually resolve by the end of the day, latest the next day.
Great. So that's good. No treatment needed.
Yeah.
For those patients. So you talked a little bit about arthralgias earlier.
Mm-hmm.
If someone has swelling or arthralgia that self-resolve, would you proceed with the next dose as scheduled? I'm assuming yes here, but basically what you just said before, correct?
Yes, I would. And the question,
Maybe a slower rate.
I would definitely do a slower rate, but with the next day arthralgias for hours afterwards, I would probably pre-treat them with a steroid or change the formulation. Because if somebody's having flu-like symptoms or arthralgias with a certain formulation, they're likely to continue having that. And there's actually only one formulation where I've seen that consistently, and that's low molecular weight iron dextran.
What are your thoughts on when you are monitoring a patient post-infusion? Should the clinician monitor orthostatic vitals?
I don't know the benefit of that. If somebody's orthostatic, we will know it.
Yeah.
They will usually complain of symptoms of orthostasis, which is dizziness upon standing.
Yeah. I think about my days in the ER and how many orthostatic vitals I've taken. Position the patient, take their blood pressure and all vitals, set them up, do the same, repeat standing, and then sometimes multiple sets of those. So it can be very time consuming. And imagine the nurse that asked this had these questions, because if it's not something that's absolutely necessary, then we probably shouldn't move forward because it would save a lot of time.
Yeah, exactly. So this also goes back to the post-infusion monitoring and about saving time, watching patients for 30 minutes. If you do that consistently with every intravenous iron formulation, it adds up, and imagine how much time you can save if they just got up and walked out after their infusion.
Yeah, so much time. So is it appropriate to restart iron infusion if a patient has symptoms of CARPA in the home care environment?
Ooh.
Yeah, we didn't talk about that. We didn't talk about different environments and what that can mean for potential reactions and or risk because of the associated resources within a specific care environment.
Yeah. Well, I guess my question would be, is there an emergency kit available, right?
Yeah.
Are we able to monitor blood pressure? So are we able
Yeah.
to monitor vital signs? And if not in the home
So
setting,
say that we had, because I'm assuming, and this is assuming, and if not, you should have this as a home infusion nurse, but you should have your kits ready to monitor vital signs. And then potentially, if this patient's high risk, maybe they even have an EpiPen.
yeah, absolutely. I think
Okay.
if we're giving any kind of intravenous form medication that has the potential to ever cause anaphylaxis or some kind of infusion reaction, then the appropriate medications or treatments should be immediately available.
So it's safe then, right? If they had CARPA before, it's not, if it's truly CARPA, again, it's not, we're not hypotensive, we're not tachycardia, and we don't have the swelling of the throat or hard to breathe, then it's CARPA and not a true reaction. So within that, you'd be safe to go with the next dose in the home setting, as long as you had the appropriate resources available to ensure patient safety.
Yes, absolutely.
Great. All right. Well, that's all the questions I have for you. Do you have any final thoughts before we wrap up today's episode?
Yes, I want to say that I always prepare patients for the potential for side effects. I always counsel them and discuss them when I am suggesting intravenous iron to them. So, this is something that the ordering clinician should do so that if a reaction does occur, the patient's like, oh, okay, my doctor did tell me, or the nurse practitioner did tell me that I may experience this. So, this is normal so that they're not too alarmed.
It really takes that shock factor out if we do our education on the front end and explain to the patients that you may experience this, but we know what we're looking for, giving them some reassurance as well.
Absolutely.
So that's it for today's episode, but join us for the next episode where we're going to talk about recognizing hypophosphatemia and how to manage it. And again, Dr. Van Doren will be back with us to discuss this very important topic. And as always, I'm your host, Derek Fox, and it's been a pleasure sharing this important discussion with you. Remember, knowledge empowers us to make informed decisions. Until next time, stay informed, stay curious, and keep gaining knowledge. Thank you for tuning in.
Infusion complete.